Welcome to the Roetzel HealthLaw HotSpot. HealthLaw HotSpot is a podcast for physicians and health professionals that covers the legal issues and trends that affect the healthcare industry.
Hello, everyone. Welcome to the HealthLaw HotSpot. This is Ericka Adler. I am the head of the Health Law Department and a shareholder at Roetzel Andres. And today I'm joined by two guests and one co-shareholder partner, David Hochman. He's part of the Health Law Group, and he's also the partner in charge of our Chicago office. And we have a very special guest, Lucy Zielinski. Lucy and I have worked together for many years, and I'm very excited to have her here today. She is part of the Lumina Health Partners. She specializes in helping health systems and medical groups achieve top financial and operational performance. She has more than 25 years of experience in achieving optimization through physician-hospital alignment, which includes clinically integrated networks, value-based programs, telehealth services, coding and revenue cycle improvement, as well as physician leadership programs. Lucy's a big believer in investing in leadership, strategy, and technology as a company's greatest investment. She's also an industry-renowned thought leader who's been featured in numerous healthcare industry publications, including HFMA, AMGA, and even MGMA. And I'm so excited to have her here. We have worked together for a long time with many of our clients, and we have spoken together on topics in the past. And today what we're going to be talking about is really how our physician practices primarily doing now. We just started 2021, and it's been kind of a hectic 2020, as everyone knows. And people are starting to think about their performance. How can they improve their performance from last year? What went wrong last year that they hope to correct this year? Not everything, of course, was within their control. But as we kind of head out into 2021, what are some of the things that they should be thinking about, they should consider trying if they have not? And they should consider that they may not have even heard of. So why don't we first kind of hear from you about what you're seeing as the biggest impact that people have, the biggest things that they've been impacted by so far in the past 12 months, let's say, and then we'll go from there.
Great. Well, thank you for having me, Ericka. As we all know, we had COVID, right? And with the pandemic, providers definitely took a financial hit. Visits had slowed down, their volumes in their practices, patients were coming in the office. So one of the good things that happened is there were provider relief funds, and those funds definitely helped pay for some of the expenses that the physicians have, as well as some of the lost revenue. They covered that as well because the lost revenue, patients weren't being seen in volumes like they were before. The good news is there's also a second round of PPP that's up right now. So COVID definitely impacted physician practices. I think another point too is physicians, because of the pandemic, had to pivot really quickly and implement and adopt telehealth services. I can tell you a story. My primary care physician of mine, I think she overnight implemented telehealth services. I'm not kidding you. I mean, with her smartphone and just using that and then adopting some other technology, she was up and live within a day. And definitely telehealth is expanding. We see that in the new rule, and there's a lot of services that are covered on telehealth. It's interesting. There was a statistic that I saw the other day that it's forecasted that by the end of this year, by the end of 2021, more than 30% of consumers will access care virtually. So wow, that's like 1 out of 3 people are going to be using telehealth services. And I can tell you, I'm one of them.
We're seeing it in some specialties I wouldn't have expected either, right? Like gastroenterologists, I have dermatologists using it. I think almost every type of specialty could use it to some extent. It may not be for like the primary visit, but certainly like follow-ups and initial assessments and stuff like that. So it could be a good opportunity for those who haven't already considered it.
Absolutely. And even not only physicians, but other providers as well. Like therapists. I mean, we're seeing a lot of counseling and mental health services being provided via telehealth as well. And dermatology, like you mentioned, some of the specialties, dermatology as well. So we're seeing an increase in not only primary care, but specialties also use telehealth services.
Great.
Mhm.
All right. And I know there were a couple of other issues that we really affected our practices a lot this past year. And I kind of want to cover those before we talk about, what the future holds and what people should be thinking about. One of them you mentioned to me was a shift from inpatient to outpatient. And I'm guessing that this is really, hospital-based surgical procedures that are now moving to surgery centers. But what other kinds of services are you seeing changing in that way?
Yeah, and before I answer that question, I think the reason we have to ask why is that shift of service occurring, right? Well, we're seeing continued growth in value-based care and payments being tied to risk-based contracts, as well as growth in Medicare Advantage. Medicare Advantage has grown over the last few years quite a bit. I think the statistic today is there's about 39% penetration with Medicare Advantage, and that's only anticipated to be increased here over the next few years up to 50%. So everybody is looking at quality, how quality is delivered, but the cost of care as well. So this shift in site of service, right, from the inpatient environment to the ambulatory environment is definitely growing for that reason. We're seeing hospitals be repurposed. And like you mentioned, increase in ambulatory surgery centers, an increase in urgent and immediate care centers, as well as retail clinics. I think one of the reasons here is obviously the cost is a driver, but access is another point. So patients can access those centers more readily than they can emergency department at a hospital where they may have to wait hours, right? So that's another reason you're seeing that shift in.
Do you think the events of the past year kind of slowed things down from where they might have been? I mean, obviously our focus has really been, we had surgery centers that were shut down, right? We had a lot of places opening up or expanding to offer COVID testing, which they weren't before. But, where would we would have been somewhere further along, I would guess, if this hadn't happened this past year. Have you seen people negatively impacted by kind of the slowing down of that, where they had business plans, in progress? I haven't really heard about that, but I'd be interested to know.
Yes, they were definitely impacted financially. You're seeing hospitals and medical groups kind of go into this mode of what is our financial recovery strategy, because their revenue definitely took a hit, especially some of the ambulatory surgery centers as well as hospitals that rendered those the elective surgeries and your routine wellness visits, right? Mammograms, colonoscopies, and the such. So those centers definitely took a hit in revenue. And what I'm seeing is they're looking at their cost as well. And they're trying to decrease their cost just to have the margins and manage the margin.
Right. So now we know this past year has been a crazy year, but there's some good stuff that came out of it, right? We got some telemedicine. Looks like the government's going to preserve a lot of that, the reimbursement and a lot of the very quick expansion that occurred. It looks like it's here to stay, which is a great opportunity for many practices to take advantage of. But for those practices that, maybe they just were doing, so-so all along, or they were particularly hard hurt by, the events of the past year. Maybe they're just like, ready to do great in 2021. Really looking to talk about some very practical options that they can and should be considering going forward to kind of knock it out of the ballpark this coming year, or maybe it's a 2-year plan or whatever it is, but just a change in status quo. So really what we want to talk about are what are some of the things that they should be doing going forward in order to achieve the best results.
Mm-hmm. Yeah, and I'll say this in jest for a moment, but it's true. you definitely want to figure out how to keep your patients and grow your patient base, right? It's pretty that simple. So how do you keep your existing patients and grow? We know that many practices, it's really word of mouth, right? And these days, I should say, word on the internet. So what is being published, what is being said and commented on in social media is definitely as important as, the neighbor next door providing you a referral. So keeping the patients is key. I think what I mentioned earlier is access. Patients want convenient care. So increasing the access to care is important. So physicians should be thinking about how to provide the right care at the right time to patients. So if patients are calling, timely response calls back to the patient, right? If they are asking questions on the online portal, that practice should be responding to that patient in a timely manner. Also, access to care. So maybe expanding the hours into the evenings or weekends or mornings. And that easily can be done via telehealth services too. So telehealth is really key to expand access in practices.
I think those are great points. And, it's interesting, and David, I'm sure you'll agree with me, is that we work with a lot of physicians. We do a lot of physician contracts. And one of the biggest things that we fight for when we're representing a doctor going to a group is no touching my schedule unless I agree. And if we represent the group, we're like, you work when we tell you to work. So when we're talking about what's best for the practice in terms of expansion, weekend and evening hours, you got many doctors that are like, no way, I'm not doing it. But I guess that telemedicine element allows them to work more hours, make more revenue, and maybe do it from home even, right? Dave, what are your thoughts on that?
I think those are valid points. I think that what I saw during the pandemic is people were looking for ways to recoup some of the income they were losing because they were shut down, patient volume was off. So we had people started doing COVID-19 testing. And that actually turned out to be very helpful for some of the groups. Telehealth, and I don't know, Lucy, if you've seen any other, I guess, different product there, different service areas that people have gone into to try and keep themselves afloat and during the pandemic. The other thing I was wondering is talking about patient access to care and keeping the patients is vital. Are patient satisfaction surveys worth the trouble?
Oh, absolutely, they're worth the trouble. First of all, they provide an insight into improvements, right? So how do patients perceive your practice, your staff, your care that they receive in your office? So that feedback provides some insight into what you can do better. Secondly, one of the other reasons you want to do patient satisfaction surveys is some of the quality programs are tied to satisfaction surveys. It's a requirement. And we see that with some of these quality payment programs that they do require patient satisfaction surveys to be done.
And that's interesting because I never take the time to fill those out. I mean, I get one every time me or one of my kids goes to the doctor, but you have to log into the portal and I can never remember my password or whatever. So I'm like the biggest problem with them getting those surveys completed. I mean, how do you deal with somebody like me who doesn't have the time or the information?
I get my dentist sends me every time I go to see him, I get a survey. And if I don't respond, I get a follow-up in about a week until I finally respond. So
I just never respond. But I could see why it's important.
Persistence is one way.
So does it have to be through the portal? I mean, it's such a pain, the portal.
Well, it's interesting, depending on the survey, right? But if I had patients where I did not have good results coming back in, I would probably do a survey when at the visit, right after the visit, at the conclusion of the visit, I would say, Ericka, would you mind doing this quick survey? And you would say, sure.
Yeah, I mean, I would probably do it then, I guess, but it is a pain, and with every different provider having a different portal and a different password, and that really is an issue. I don't know if one day we'll have a better system, but that for me, I'm not that old, but I can't remember my passwords. And, there's a lot of people not savvy on the computer, and I don't know how they even deal with it, but it is an important feature of those programs that are checking out value. So are you finding that a lot of practices are participating in those type of programs? And if you're not, should you be?
Great question. Absolutely. Every single practice, every single physician should be participating. If they see Medicare patients, they're participating in MIPS, whether they know it or not. So they are participating in the quality payment programs. And there are incentives as well as penalties. And this year, it's a negative 9% penalty that it impacts your Medicare payment. So and most physicians should already know about this. So I'd be surprised if there's a physician out there who is not participating in submitting data. But if they're not, they definitely have a ding on their payments.
What about other private payers? Are they trying to compete by offering similar programs, and are those optional or mandatory?
Yeah, absolutely they are. It varies depending on where you are in the country. And those value-based contracts and private payers, commercial payers are definitely offering those to providers. Historically, you would be able to get an increase on your fee-for-service payments each year. That hasn't been the case for several years now. And so the way you make up that revenue is really through those quality-based programs. Pay for performance. You're taking a look at some quality metrics, making sure that patients receive the quality care, and those measures, the performance on those measures is, performing at a high level, and that equates to incentive payments. So that's how physicians are able to get some additional dollars in those value-based contracts.
Yeah. Are you seeing groups implementing those metrics in their compensation formulas now?
Absolutely. Absolutely. And that's a great point, David, that you bring up, is historically, those have not been included in compensation. I mean, if we take a look at compensation models of the past are based on fee-for-service revenue, typically those were based on a base salary or a production-based bonus based on work RVUs, or maybe tied to some financial revenues as well. What we're seeing now is probably 30%, 20 to 30% of those physician compensation models are now tied to quality or performance-based metrics. And some of them are pretty simple, like if you click the button and start measuring quality, you will be compensated. So I see organizations just incentivize their physicians to report or to participate in these programs, right? So it's easy entry, and you can get those bonus dollars fairly easily.
I mean, I see larger organizations doing that, like closing your records in a certain amount of time, or having a certain turnaround time on some other measure. But are you seeing that at all for non-institutional practices?
Yeah. I have a few clients. I have one client who's been doing this for 6 or 7 years.
Wow.
So the part of the compensation formula is based upon the doctor achieving certain attendance at marketing efforts, being active in the community, being active on hospital staff. But where I've always seen it for a longer period of time is in hospital-based groups that are getting some financial support from the hospital. Some part of that support is tied to achieving a whole dashboard of metrics, and they're all designed to promote quality of patient care.
And sometimes it's extra money, and sometimes it's coming out of their own money, right? So here you earn this productivity bonus, but 20% of the productivity bonus is only going to you if you meet these measures. So it's kind of like, to get your own bonus, you have to meet these requirements, which I guess incentivizes a little bit, but that's an interesting way to do it. I expect we'll see more of this going forward. And what about clinical integration as well? Because that's kind of something that's becoming a lot more popular. When I look at quality measures that are tied into bonuses, I'm not really so much seeing clinical integration components of that. Is there a way to kind of tie your participation in the efforts of your employer with regard to clinical integration to compensation as well? And are you seeing anything like that?
Yes, and I think, David, you hit on that. You're starting to see a dashboard, right? So what we do quite a bit of work in compensation model redesign. And the primary question we're asking is, how is the organization getting paid? Where are the bonus dollars? What are the bonus dollars tied to, right? What behaviors you would like physicians to modify, change, or engage them in? And then once you determine all of that, you can create a compensation model or a percentage of their compensation that is tied to those metrics. So the key is to align where the organization is as far as their contracts and their strategy as well to that compensation model. So to your point earlier, like those citizenship metrics, like showing up to meetings, helping out with marketing, attending classes on HCC documentation because it's important for Medicare Advantage patients because we're growing in that area. So those citizenship as well as those quality metrics are very key.
All right. So tell us then a little bit more about the clinical integration piece of this, because we're hearing so much about it. I know Stark and anti-kickback and even HIPAA have either proposed or have passed changes that really relax those requirements because they're encouraging us towards clinical integration. And how can clinical integration really impact our clients? And here we're really talking about physician practices. We're not talking about hospitals, but our physician practices, how can they get involved with this? Is there opportunity, or is that something that they don't need to spend time on?
Yeah, they should definitely spend time on this. One of the things that physicians need to think about is how do they participate in some of these different models, especially if they're an independent provider on their own. Because these groups are now negotiating better contracts and rates with payers in numbers. So volume is very important. So partnering with, especially the independent physicians, right? They should be partnering with clinically integrated networks or accountable care organizations, ACOs, to be able to leverage that volume and participate in value-based contracts and achieve some additional revenue based on what's required to participate. And one of the things with clinically integrated networks aims at is obviously to reduce the cost of care, but more importantly, to provide better care to the patient population. And that is really done through quality-based programs. So we're seeing a lot of care management going on in these clinically integrated networks and ACOs where patients are better managed across the entire network, right? They're pulling data from not only the physician practices and the specialists, the post-acute facilities, and the hospitals as well. So they're taking a look at that entire record in total to see what care that patient needs, especially for that rising risk patient, right? If you see some markers for where that patient may be chronically ill, you're bringing that patient in and treating that patient earlier than you would should there be any complications down the road, where then quality would go down, cost would go up, and that sort of thing. So it's better care management for the patients.
So your role would be, depending on your specialty, to kind of be looking out for certain things within your patient population. So if you're, allergy and asthma, you'd be looking to manage those kind of features. If you're, what I guess a better question would be, where can the average physician visualize themselves being in that clinical care continuum? I mean, if you're a primary care doctor, where do you fit into that?
Yeah, well, it starts there. It starts with primary care. Primary care is the most important because you're seeing the patient more frequently and managing that patient chronic conditions. And then you have to have a solid network of specialists as well. And then every specialty, every physician, every provider then comes together to provide services to the patient. So that's where a clinically integrated network or an ACO can support by consolidating all of that data, right? And taking a look at that data and identifying the patients that need care management services or patients who are, the risk is rising and who need to be either be seen or sent to a specialist. Or another one could be like closing the loop. I mean, if you have a diabetic who's out of control, who hasn't been seen in 6 months, or hasn't received preventive, exams, foot exams, whatever some of the quality metrics are, it's an opportunity to identify that patient and then bring them in for services.
That makes sense. And I know you and I have worked recently together on trying to bring together physicians to potentially start their own ACO. And, so for doctors out there who may not be part of an ACO that they believe in, or may feel like their specialty and their colleagues, specialties present an opportunity to come together to create an ACO, that is a possibility as well. You do need a certain volume of patients and of primary care providers as well. And I guess one of the things that I'm thinking about when it comes to primary care is we know this coming year in terms of reimbursement, that primary care reimbursement it will be higher than it was, correct? But some specialists will see a decrease perhaps in the reimbursement. But what can our practices expect on that issue?
Yeah. So Ericka, you're referring to the CMS, the physician fee schedule final rule, right? That was published, and these rates go into effect this year, January 1st. And you're absolutely right. Some of the major provisions include that conversion factor has decreased about 3.3%. So overall, there will be a reduction in payments overall. However, there has been some shift in the E&M visits, which these are the evaluation and management, the office visits, if you will. The RVUs have increased on those CPT codes, on those services. So because of that increase on those work RVUs, there's going to be two impacts. You may see increase in payments on those services. And also because of the work RVUs, because they increased, think about this. If your physician compensation models are tied to work RVUs and there's an increase in those work RVUs on those office visits, the physicians will receive an automatic raise. And so I urge organizations to do an impact analysis, because if there are high utilizers of those E&M services, that raise could be as high as 25%. And so organizations should really be taking a look at that and considering that.
Wow, that's important to think about for just the average people who haven't looked at their contracts, the groups that haven't really considered their models in a while, how they're going to be impacted this year.
Mm-hmm. Right. And you're right. The specialists, their work RVUs haven't shifted much unless they see a lot of E&M patients, but the conversion factor decreased, so they may see a dip in their revenue.
Wow. So if we're out there and we're talking to our practices, and I just want to kind of make sure we're staying in our lane here, what other ideas do we have for things that they could be doing this year? I mean, one thing you and I have talked about in the past is how do they increase their bottom line? I mean, could it be bringing in mid-levels so that they can see more patients? That's always a possibility. Offering new services like telemedicine is one, but they could expand and consider offering additional services. One topic that is very hot, and I myself am going to talk about this in the weeks, going forward, are a lot of primary care doctors trying to dip, and other non-primary care doctors dipping into areas that are typically, not ones they've gone into before, like cosmetic type areas, the med spa. It's so lucrative. A lot of people pay cash. So you have doctors kind of going to that, which can be great if people really appreciate, though, that need to know what you're doing and supervise appropriately, et cetera. Do you see any other items like products or services that people should be thinking about in terms of, if you don't do more or sell more, or how are you going to make more? So is there something that our clients should be thinking about?
Good question. Physicians are very creative. They are very creative. So you're right. They're selling from cosmetic to, there's a lot around weight loss clinics, Botox. I mean, we see all sorts of things. If we go kind of the traditional route and ask the question, what should physician practices be doing? I think telehealth is number one. I'm assuming they started that already. If not, That's something to consider. The second is considering expanding the providers and using these APPs, the advanced practice providers. I have one primary care practice that the physicians are at home doing telehealth visits, and the nurse practitioners are in the office seeing patients. And their volume has doubled in the last year because of the fact of these APPs. So definitely consider adding on the advanced practice providers. Care management service is another one. So when physician practices partner with some of the ACOs or CINs, they can potentially provide care management services, and that's another service line. They could provide those services and be paid for those. Another thing I'm seeing too is the incorporation of like behavioral health and social work into the primary care office. So we're seeing a lot of these practices expand that primary care strategy, if you will, by incorporating some other specialties.
Those are great ideas. I know my clients ask me this question all the time, David. I assume you as well. What can we do better or differently?
No, we've had clients who've now gone into weight loss counseling and behavioral health, and those seem to be a couple of areas that are relatively new development.
Yeah, and cryogenics and infusions are pretty popular now as well. So Lucy, one more question, and then we can probably wrap this up. But definitely, we have so much to talk about that we'll have you back on a different day. But I guess, there's some basic stuff that just goes on in a practice that people don't do very well. And I know you and I have talked with practices about, how well are they billing? How well are they collecting? Are they pursuing every dollar that's out there? So, that can often be a very simple way for them to improve their revenue, just doing a better job. So I kind of just want to hear from you about what are some simple things that they should be considering if they haven't looked at, what they're doing lately.
Yeah, that's another good question. They have the data. They should be looking at their data. The first question is, what other services? How can we expand services and bring patients back in? So closing the loop on orders that, are still open, bringing the patients back in for follow-up visits, for refills, for annual preventive visits, for annual wellness exam, for depression screenings, whatever that is, bringing those patients back in. Immediate revenue, right? And then I think the point you mentioned is really about effective management of the revenue cycle. And gosh, I've spent probably most of my career in that revenue cycle space. And there still is, I would say on the average, an opportunity to improve that revenue cycle, resulting in 5 to 25% in additional revenue, because it's not efficient in many, many physician practices. They think the biller has it, it's a billing job, and they're doing it. And what I often find is there's an opportunity to improve denial management. There's an opportunity to appeal claims that may be written off for whatever reason. There's also an opportunity to take a look at and redesign workflows. For example, that front end process is so important. And if you have a high denial rate, let's say you have a denial rate of 20 or 25%, that means 1 out of every 4 claims are being denied. That's very high. So I would ask the question, why are they being denied? And what can we do better? What I find, it's usually that front end process, correct insurance information being entered into the system. Is the patient eligible on date of service? Was the procedure, authorized or not? And those sorts of things, many of these systems now have the capability. If not, there's a lot of AI that's available that can support this. So you don't even need additional resources because there's quite a bit of technology to help optimize that rev cycle.
Oh, that's great. And that's so helpful. And, I know smaller practices, often they're doing everything themselves and they don't know, what to change or who to talk to or what they don't know, right?
Yeah, I'm surprised at the number of small practices never do any revenue cycle management. And, they say, well, I'm not as successful as I want to be economically, but I can't figure out why.
Right.
I think that, having that reviewed is important for a lot of reasons. I think the people in the office who are doing the billing may know what the rules are when they start, but are they keeping up with all the changes? And are they coding things the right way? So there could be money, they're leaving money on the table. In the worst case scenario, they're overbilling.
They're creating compliance issues.
So
Right.
I think it's not just a question of doing it to make money. There's a question of doing it to keep yourself in compliance.
That's right. And David, one of the things you mentioned earlier is the dashboard report, right, of key performance indicators. I would definitely, especially for the provider who's the owner, has oversight over the rev cycle, there's probably a handful of key performance indicators the provider should be looking at on a monthly basis. And those are indicators or red flags that could be looked at. And if it's out of target, to say why, what's going on. So a couple ones I would look at: days in receivable, collection rates, denial rates. What's the lag from date of service to when the claim is processed, right? If that lag is 2, 3, 4 weeks, we have a cash flow issue, right? So looking at those measures is important.
That's so great. That's really helpful. All right, so I think we'll wrap up this for now. And Lucy, you're such a great source of information. I hope everybody listening will feel free to reach out to Lucy. I know she's my go-to person for these kind of questions. I've learned a lot just from hearing you today, but over the years for sure. Are there any final thoughts that you or David, both of you, want to share about what our practices should be thinking of this coming year in kind of, like I said earlier, knock it out of the ballpark?
Well, I think that Lucy had some great ideas. I think there's a lot of ways that practices can look to improve themselves that don't require large outlays of money. It may take some time, but they're pretty cost efficient. And I think there's a way for that to flow through to the bottom line. So I think those are very helpful ideas.
Yes, I agree, David. And I think practices have to think creatively. We are in a time of change. We are in a challenging time. There's financial pressures. There's changes with value-based care, how physicians are paid, and these regulation changes. And so keeping an eye on that and seeking, support from other professionals, I think, is important as well. And one of those things is the ACOs, the clinically integrated networks, partnering with groups like that, I think is definitely a recommendation I would have for groups.
Great. Well, thank you both so much for joining us today. This has been the HealthLaw Hotspot, and we hope you'll join us next time. Thanks so much.
Thank you.
Thank you.
The Roetzel HealthLaw HotSpot is made available by the firm and its attorneys for educational purposes and to provide general information, not to provide specific legal advice. Use of the Roetzel HealthLaw HotSpot does not create an attorney-client relationship between you and the firm or any of its attorneys. The Roetzel HealthLaw HotSpot should not be used as a substitute for competent legal advice, and you should contact an attorney in your state about any legal needs or questions you may have.